everyone. Welcome to the monthly ASBA webinar, Pediatric Patients in the Laboratory. Amber Gaylor will be the presenter. Amber graduated from Weber State University in Ogden, Utah with a Bachelor of Science degree in respiratory therapy. She traveled with faculty members to West Africa on multiple occasions for humanitarian trips. She also taught CPAP to physicians and graduating respiratory therapy students in China. She is currently employed at Primary Children's Hospital in Salt Lake City, Utah. Amber has been involved with the Utah Society of Respiratory Care, an affiliate of the American Association of Respiratory Care, AARC, since 2008, and just concluded a term as president in December 2013. She is the political representative for the respiratory profession and patients in the state of Utah, and also works with the Tobacco-Free Task Force of Utah. Thank you, Amber, for sharing your expertise with us. We will not host a webinar in May due to our Sleep and Wellness Conference. I will email you the survey in the next few days. Please email me the survey back in order to obtain a certificate. I will issue the certificates in approximately 2 weeks. And now, pediatric patients in the laboratory.
Thank you, Julie, for that amazing introduction, and to the American Sleep and Breathing Academy for having me do this webinar and this amazing opportunity. I'd like to thank everyone for tuning in today over your lunch break to hear my perspective on my every night routine at the Pediatric Sleep Lab. I do not have any conflict of interest or have been paid financially or had any professional or personal interest with any product to influence my presentation today. I'd like to start with a summary of the presentation and go over what this lecture will describe and what we will talk about in examples. The most importance of the age-specific measures to gain a successful sleep study in children. I'll go over some examples of hookups and solutions that will be in contact with pediatrics and the use of different montages and what we use them for. The importance of capnography in the pediatric sleep and where the line is drawn between abnormal and normal breathing. The learning objectives follow the summary. Throughout the course of the webinar, the attendees should be able to observe and understand basic interactions with children, recognize the challenges in the hookup and the procedures, and any adjustments that need to be accommodated for. Attendees can gain knowledge in appropriate montages and be acquainted with the use of capnography and its readings and understand normal versus abnormal breathing in children. We'll first start out with defining the fear and anxiety in children. Most patients that come to a sleep lab are aware of the procedure, have a referral from a physician, have done some research on what they do at the sleep lab. Older patients recognize that they will be away from their sleep schedules at home, away from family or friends, and know that it'll be a short period and know that they'll be in good hands at the sleep lab. Imagine being a child coming to a strange place where people in scrubs, they're security guards, they know it's either a hospital base or you're just going to the strange building, not knowing if your parents can sleep with you or stay with you, if you can eat or drink, who will help you go to the bathroom once you're hooked up to all these wires, if there's anything that you should be scared of. Most of my older patients have a fear of zombies coming to get them, or have talked about being electrocuted by the wires. Littler patients think they're going to get a shot or be cut open or the stickers will hurt, or the wires will hurt, and really just don't want to interrupt their nightly routines or their fun time being at home with parents and hanging out in pajamas and being able to go to bed in the comfort of their own home. So to try to clear up the anxiety and the fear is the number one thing you can do for these patients. And gaining their trust is going to get you your successful sleep study. Describing the process in age-specific vocabulary and examples. If I have to get a patient's height and weight, I don't tell them, let's go get your height and weight. That gives them some sort of misconception that I'm going to steal height and weight. I want to explain to them or talk to them at their level and say, let's see how big you've grown this month, or let's see how tall you are. Are you taller than me? Are you taller than mom, brother, or sister? And start getting them excited that way. And those first steps are what's going to ease into being able to put the electrodes and the tapes and calming these patients down before bed. Pictures and hands-on demonstration is very useful, using teddy bears, using toys that they've brought in themselves, putting stickers on that toy, putting electrodes on the toys, reading books and pictures for CPAP patients and BiPAP patients so they can see the other kids go through what they're going through, and they will be more happier or excited about the CPAP mask you're going to put on them, and less fearful of maybe the air that they're going to feel. So having them play with the equipment, having them touch it, and being able to wear it or put it on mom or dad, giggling about it, is going to make the process a lot easier for both of you and give you that study that you need. Using all 5 senses and proving to this child that nothing you do is going to be hurting or anything that they should be scared about. When I say all 5 senses, I don't mean tasting the glue or tasting the supplies, tape, or whatever, but having the child suck on a binky or using a bottle, or even having a drink at the bedside, or even a sucker or something, a small treat that they can be distracted with while you are placing all of the equipment on the child. So having them touch the sensors, having them place it on mom or dad, having them smell the glue and smell maybe the adhesive on the tape, and then having them look at the electrodes and seeing that there really is nothing that can hurt them. And getting the child as active as possible in the procedure before it actually begins. Creating a child-friendly atmosphere is very important. Having a safe, comforting environment that they feel welcome into, having blankets, pillows, any books or toys that are for that age group available in the sleep lab that they can be reading while you're setting up, adjusting their bed, having their pajamas on, ready for the setup, is going to assist you and the child in having the successful sleep study. At our sleep lab, we will provide a pillow case and a blanket, and that they can take home in the morning to remember their sleep study and remember the fun time that we had having this, and making it not as scary or fearful for this child. Having gender, age neutral things on the walls or in the room is going to make them feel more welcome. So posters and wall decorations with maybe animals or landscape, If you have a 10-year-old boy in a room that likes sports or likes action figures, and he's in a room with My Little Pony or butterflies or something that he can't relate to, may make him feel that, just not like he wants to be in there. And same for a girl. If the female doesn't want to be associated with boy things, she's not going to want to fall asleep. Using sound machines can be helpful to mute distractions. If you have a patient in the other room who's crying or screaming and not wanting to be there, can upset the other patient. So having those sounds that are calming, waves or water running, or things that they can focus on to help them fall asleep, are used. Some patients have a hard time falling asleep without air blowing on them, or have ceiling fans at home, so having a fan available for the ones that want it can help, and also mute distractions from other rooms or people walking past or housekeepers moving carts. Having a CD player available in the room that they want to listen to music and calm down that way. Having soft music playing can also help calm the nerves of the person setting up and the patient. Bringing things from home are definitely encouraged. Pillowcases, blankets that the patient has slept with for years and years and years. Having the patient, if they feel more comfortable, even sucking on their thumb, tell them that this is not something that they should be afraid of and can still do in the sleep lab. And let them know that we just want to keep everything as close to home as possible to make it as comfortable as possible for that patient. Be versatile in setting up the patients. Having babies and smaller children may feel more comfortable sitting on mom's lap in the bed while you're hooking up wires onto their head and their bodies. Small children have been told about stranger danger and start to worry about, well, why are you putting this on my legs, or why are you putting respiratory electrodes on my tummy, lifting up their pajamas, or sliding the wires through so they are kept secluded in the back of the patient so they're not rolling around in them. Having these patients in a car seat that are used to sleeping in car seats or in elevated beds or cribs are useful, but making sure that the parent is close by, and if they need to feed a bottle or have a pacifier or their favorite blanket, or have the parents bouncing them so you can finish the hookup and then be able to leave the room quietly as they're starting to fall asleep. No two children are alike, so patients with mental and physical disabilities come in all ranges. You need to be ready to adjust your setup and adjust the way you treat each patient. Having physical disabilities can make the setup a little bit harder, so you need to be prepared to move around the bed, have extra pillows, have extra blankets, have dim lights, have all of the parents bring their medications to the sleep lab, and any mental disabilities as well need to be accounted for in treating those patients. So if you need to have support from maybe a child specialist, bring in an iPad that you can distract those patients with, or keep them focused so that you can finish the setup. Maturity levels. Bring your vocabulary down to the level of the patient. Don't treat these patients that they are understanding of your medical terms. Make up and be creative with the way you talk about even the electrodes we will call snakes, and get them associated with animals. For girls, when we use the sleep cap on them, we will talk about a princess cap, or for boys, it's a Spider-Man cap. The wires can be spider webs, and they can have some sort of play that they can associate more of a fun than a scary time. Temperaments of children. If a child is having a huge temper tantrum, let them get that out of their systems before you intervene and start putting on electrodes, tape, and placing these on their body. The child will only fight back, scream, and want to leave, start crying, even fighting back, kicking and scratching you to get away. So to prevent that, understand the temperament of the child. Work with the child first. Talk to them, get them calmed down before you just jump into getting them all ready for bed and trying to put all these electrodes on them, getting them more worried, you worked up, and it's just going to make the setup a lot longer. Nurturing of patients. Most parents have their way of nurturing their child and preparing them for bed and have certain routines. So anytime singing or praying or getting snuggling down, let the child and the parent do these nurturing routines so that it can help prepare them for a long night in the sleep lab and relieve those fears. Sleep hygiene. If a child needs certain type of schedule before bed, they eat, they brush their teeth, they put their pajamas on, they maybe sing songs and want to do a little activity. Most parents will allow their children to get all of this out of their system. They get used to this schedule, then they're able to fall asleep. We try to discourage any iPads, cell phones, watching movies in the sleep lab unless it's a special occasion that really it's a last resort on trying to get the sleep study performed. Make sure you have a team of 2. These little ones require a lot of leads, and it helps to have someone place the leads on the body and then someone at the head of the bed as well. So it's not one-on-one care, that you have someone in the room that can be a runner if you've forgotten any of your supplies or you need any help or need things brought in, and you have an extra hand in case a patient gets sick or has wet or has an accident, then you're able to hurry and switch out bedding and supplies as needed. A moving target. I don't think I've had a patient that has sat still for an entire setup for the entire length of the time without moving. So be one step ahead of the game at all times. These children are very unpredictable and can get out of the way of your hands or the parents' hands quick. So have all your head leads, your body leads, your skin adhesive tape or any Me-Fix, your cannula, thermistor, or pulse ox right at the bedside and are able to grab it fast and place it fast if needed. Having an intensified moving target. Patients that are on ventilators, make sure they have humidifier circuits and sterile water in place and set up so that when the patient is ready for bed, everything is at the bedside. You could just turn it on, start your titrating, and leave the room at that point. Have your high flow nasal cannula, your humidifier, your circuit at bedside. You don't want to be leaving to go find these supplies or finding out that your equipment doesn't work as you're ready to turn out the lights for the study. It only prolongs the before you can turn the lights out and start the recording, and it also creates anxiety and stress not only for the patient but the parent as well. Have your CPAP and your BiPAP equipment set up ready to go so you can just place it as soon as the patient is ready to fall asleep. If you have a patient that is currently on CPAP or BiPAP, it's okay to place their mask and turn the flow on while they're reading a book or talking to parents or waiting for the lights out. Some patients that have not experienced CPAP or BiPAP are going to be unfamiliar with this procedure and not wanting to wear a mask for the first night of the sleep study and creating a more difficult first night effect for those patients. And you will not get an accurate reading or titration on those settings. So make sure you put your CPAP mask or BiPAP mask on right when the patient is ready to fall asleep. And that way the parents can help calm them down and get them going. If you put it on too fast, the CPAP or BiPAP machine is or mask is gonna be thrown across the room, torn off, taken off. The patients are gonna start scratching the head straps, moving your head leads, making it more difficult to replace them and trying to get your CPAP back on. Once your CPAP mask is removed and thrown away, it makes it more difficult each time to replace it and start over. If you have a patient that has a tracheostomy, make sure the supplies are in the room and close to the bedside in case there's any emergencies. Trachs do fall out, they get pulled out, they get untied, and may need to be suctioned during the night. So be prepared for all circumstances and emergencies with the patients. Small, younger patients do not want the trach in. They try to pull it, snag it, and when you place that cap on for a cap study, they start to get anxious and wiggle around, flail their arms. So you want to have everything right at the bedside, extra caps, so you don't have to keep going in and out and disturbing the patient. We use several montages in our sleep lab. Our main one that's used is a baseline and PSG. And I'll click over to the next slide really quick and just show you an example of that and how we cross-reference the leads that we place on the patient's head. So we will use the leads on the central lobe, the frontal lobe, and the occipitals, and then the A1 and 2 behind the ears. And then my next slide, I can show you where those are placed and how they are measured. So with the cross-referencing, we can see exactly which lead that comes undone or may have artifact that we can go in and just switch out and do this in the dark without even disturbing the patients. So just going down the list, you can see that C3 is cross-referenced with A2, C4 is cross-referenced with A1, O1 is cross-referenced with A2, and O2 is cross-referenced with A1. Then you have your left eye and your right eye, and in this picture, it's showing you that you're in the stage of REM with the rolling eyes. So you'll have your chin, and in REM, you won't see a lot of artifact from the chin movement. As be more relaxed, you can see that maybe when the patient's coming out, there's more of a vibration or an artifact towards the end of the 30-second epoch. Below that is the EKG leads, and you can see in the chin that there may be some EKG artifact as well. You try to get as less of that as possible, but you can change your sensitivities and your settings so it doesn't show up as bold and as dark. You have your snoring mic, which is placed right either side to side of the Adam's apple. If you have a patient that is that has a trach, you need to go either below it or above it, depending on where the trach is placed to get that artifact, and to get that reading. You can get vibrations in the snore mic on a patient that has a trach, and for respiratory therapists, you can use those vibrations as an indication for the patient to be suctioned. and go in and do that while the patient is in a deeper stage of sleep, or also use your oxygen saturations at the bottom of the screen. You can tell if the patient needs to be suctioned there. The thermistor is quite tricky, a procedure when you have a patient that has a trach. So I can go over that in the questions and answers for how we do it if you're interested in that. Below the thermistor flow, you will receive from your cannula. You can see that there is, in this example, is for the thorax and the abdominal muscles, or how the patient is breathing that way. You can also just say chest or abdomen. For your pulse ox at the bottom, you can get a clear reading that way, and your heart rate, and be able to get your respiratory rate through your abdomen and chest and thermistor readings. Going back to just the examples of the montages, we will use a full EEG montage to look for any seizures in patients, or patients that are on seizure medication have already been diagnosed with seizures. They will do a full setup on that. So I'll skip to the EEG montage example, how we do set up. And you use the 10-20 measurements. And like I said, we typically use the frontals, the centrals, and the occipitals for that, and parietals for EEGs. For the EEG montage, we can just attach it to the regular baseline and use more of the lines with the respiratory leads as well, and be able to send the EEG portion to neurology and the sleep portion to the sleep specialist, and they can review them at the same time and diagnose as a team aspect for the patient's care. Going down to the parasomnia montage, we use this montage for patients that maybe have night terrors or REM disorders or sleepwalking. And we've had patients that have had strange disorders that are unable to maybe be described by the parent. We'll use this parasomnia montage. The montage does require 2 more leads on the forearm for the contractions of those muscles during the time of the episode. Some patients have been recorded crawling around on beds, just staring off into space, speaking in unknown languages, and then not being able to tell the parents in the morning what has happened, but they feel extremely tired. All of these can be used for that parasomnia, screaming and sleepwalking. The sleep lab, they're not going to get very far because they always have the wires attached to them, but they do try and move around, flailing arms. Moving on to restless leg syndrome, we put for this montage, we put extra leads on the legs, and which is now mandatory for all studies, and are able to determine if they have restless leg syndrome, or if they're just moving periodically, or with any respiratory events. We're able to record that in those montages. For CPAP with transcutaneous monitoring and expired CO2, we are able to add a flow and do the titrations onto the screens that are just like the regular baseline PSG. And you can put those anywhere on the screen as long as you're able to see the settings and any apneic events or respiratory events, and are able to titrate off of those, and they're just added into the list onto the left-hand side, able for the technician or the respiratory therapist to make the regular adjustments for those studies. Also in our sleep lab, we do MSLT studies for narcolepsy, and it's a 2-day event where we'll bring the patient in for regular baseline sleep study or a regular baseline PSG, and then the next day do the MSLT and check for that narcolepsy, being able to measure and evaluate when they hit REM. And so they'll be in the sleep study for one full night, or sleep lab for one full night, and then the next afternoon, depending on how many naps they require. Moving on to capnography. Capnography is very useful in pediatric sleep labs. The way the capnography works is by capturing exhaled air and redirecting it to the capnography device. The air then passes between a light detector and then measures how much light is shining on it. As the concentration of CO2 increases, more light is absorbed by the CO2 and less light is transmitted onto the detector plate. This increased light absorption directly correlates with the percentage of carbon dioxide. The monitor presents the CO2 concentration in a readout of percentage and a percentage number and a waveform. The respiratory rate can be accurately estimated and reported by measuring the tides between the CO2 peaks. Measuring exhaled CO2 can provide valuable insight into metabolism and circulation. For example, take a sick asthma patient. It will demonstrate a shark fin waveform with an elevated CO2, but the patient is setting oxygen saturations at 100%. The patient is oxygenating well, but not ventilating effectively. This table represents factors that affect expired CO2. It goes down with, on the left-hand side, elevated expired CO2, changes in metabolism and respiratory system, circulatory system, and also medications can affect how CO2 is read. Causes of decreased will be changes in metabolism, respiratory system, and circulatory system. Normal expired CO2 is 35 to 45 millimeters of mercury. Above 45 is hypercapnia, and below 35 is hypocapnia. Here is a picture that is showing you the regular baselines, and it starts at 0 and then moves up with inspiratory and expiratory phases. This is a picture depicting hyperventilation. The capnograph starts normal, but then as the rate becomes faster, the waveforms become closer together and your CO2 begins to decrease. So a patient that is breathing fast is going to blow off more expired CO2 and show less on the graph. Here's a picture of hypoventilation, and there's an increasing end-tidal CO2 levels in the waveform, but it still looks normal. So the baseline is just increasing into the 50s. If your patient is showing this above 50, it's recommended in the protocols to get capillary blood gas at the conclusion of the sleep study, just to check to make sure that the monitoring levels and the patient's blood is correlating correctly. Also, if it goes above 60, you want to get a capillary blood gas during the sleep study, or if the physician requires an arterial blood gas, get that so that immediately, so that the patient can be treated effectively or intervene, possibly admitted to the hospital for any complications that they are having. Examples of decreased respiratory drive due to narcotic overdose or central nervous system depression or even heavy sedation. I've seen this mostly in patients that have muscular or neuromuscular disorders that are unable to breathe effectively and need to get that CO2 off, or just patients that are chronic CO2 holders. So you can tell just immediately by putting them on the capnograph to see how they're doing. These patients are not breathing fast enough or deep enough, and most of the patients are not strong enough to remove that extra CO2 from their lungs. So loss of the alveolar plateau is basically an obstructed exhalation. This is that fin, or the shark fin pattern that I was talking about earlier with the asthma patients. This is what it will show. This is how the reading will show. So the exhalation is prolonged and have some sort of bronchial constriction caused by asthma, COPD, or the tongue even blocking the airway. Apnea or loss of waveform. When you see this on the capnograph, make sure you troubleshoot first before you start evaluating for obstructive sleep apnea or central sleep apnea. It's possible that there could be condensation in the lines, or the patient has removed the cannula from their nose, which happens often with pediatric patients. They don't like that cannula in there. They're going to pull it, they're going to move, they're going to sleep in a prone position with their face in the pillow, sometimes have blankets over their face or stuffed animals. You want to make sure that all of these are not obstructing the flow of your expired CO2. And make sure you are able to assess if it's a loss of CO2, a respiratory event in obstructive sleep apnea, or possible respiratory arrest. Here are some examples of breathing patterns. In example A, you'll see that the chest wall and the abdomen are moving together. Their inward-outward movements are not difficult. It's a nice flow, a nice pattern. In the example of cervical spinal cord injury, in example B, you will see that the chest wall and the abdomen move inward-outward together but opposite as normal breathing. And then in example C, diaphragmatic paralysis, you'll see that the chest wall and the abdomen are moving opposite than B, but still together. These can cause asynchrony in breathing, increased work of breathing, and lead to fatigue in the patient, so you want to check for that. So normal breathing in patients is just effortless, it's clean, it creates that stable rhythm that you're looking for, the constant rate. The patients are rested, they're not moving, and the accessory muscles on inspiration are not being used, and keeping the patient calm. Here's an example of sleep stage breathing. Unfortunately, this example is a little bit outdated, but still serves a purpose. I'm looking for, in this description, stage 4 and stage 5 are now called REM sleeping or rapid eye movement sleeping. So with even the smaller patients, it's either active sleep or wake or sleep and REM sleep. So you want to make sure that you don't use the stages in infant sleeping when scoring, and you can see the way that it's used for breathing examples. In stage 1 is just a light sleep. Your muscle activity slows down. You may have twitching or a feeling like a falling going into your next stage of sleep. So your breathing pattern and your heart rate will slow down in stage 2, and your body temperature may decrease. In stage 3, your deep sleep is starting to begin. Your brain begins to generate slow delta waves, and that's an example up top how you can see the delta waves, less activity in the body. Stage 4 and 5, REM sleep, you have the rhythmic breathing starting, your muscle activity is really limited, your brain is still producing those delta waves, but now you're starting to go into the rapid eye and dreaming. Your brain waves are speeding up, and all muscles are relaxing in the chin movement. That's where we'll see very thin line. Maybe a patient will open their mouth to breathe. Increased breathing is noted in rapid and shallow. So you won't determine this as abnormal breathing if you are able to correlate your sleep stages with how the body, the physiology of the body is working. Here's a chart for normal breathing rates in children. Newborns breathe very quickly, 30 to 60 per minute, and can also vary in that they sometimes breathe very fast and then very slow, very fast, very slow. That's normal for some newborns. Some babies just have irregular breathing, and that's normal for them. So you don't need to necessarily treat that as long as you see the pattern and the trending of the breathing that is normal for that patient. Using mom or dad and asking them if that is normal for that particular time, if this is close to what they do at home. Babies will also breathe differently, sucking a pacifier and drinking a bottle while they're sleeping. So note those differences in their breathing pattern during the night with what they are doing. Also, if they're sleeping prone or moving around a lot, their breathing patterns will be different. 6 to 12 months, slow down a bit, 24 to 30 per minute. And then once they start to get older and more active, 1 to 5 years are 20 to 30, and then 6 to 12 is more of what adults will breathe, 12 to 20 per minute. So if you start to see an older patient breathing 60 per minute, you know there's something up, or maybe they have a disorder or difficulty breathing, work of breathing has changed and may need to be assessed and intervened. Abnormal breathing for these children can cause witnessed mild snoring and obstructive sleep apnea, and then in central sleep apnea is basically just the complete pause of chest and abdomen breathing, and also any flow in your capnography readings, and thermistor will also be flat. You can see it in upper airway resistance syndrome and just basically the complete or partial or complete obstruction of the airway. Here are some patterns of abnormal breathing. At the top is just a normal breathing. You can see it's just a constant rate. Tidal volume is the same and is stable. Number 2, tachypnea is just a faster breathing, not necessarily something that needs to be intervened unless it continues, because it can definitely tire and fatigue the patient. Number 3, bradyapnea is something that you want to look for, because in children they're very unpredictable and can seize quickly, and you need to be on top of that faster and not take your time watching it. For apnea, of course, it's just a complete pause in breathing, and the patient is having no flow and no chest or abdomen rise as well. Number 5, Cheyne-Stokes has the crescendo and diminuendo pattern, and it's caused by the partial pressures in O2 and CO2 changes in the patient. You mainly see it with CO2 poisoning, brain injuries, patients that are experiencing high altitude sickness, or maybe a patient that has just received IV morphine. It starts shallow and then gets stronger, deeper, faster, and then has periods of apnea that can range from 15 to 120 seconds. And number 6, you have your BIATS breathing, which is also known as cluster breathing. It has quick and shallow and not so much of the Cheyne-Stokes look, but it has the equal depth and the tidal volume, and can be seen in opioid abuse and CVAs. In number 7, you have your apneustic breathing. It has periods of prolonged inspiratory phases followed by a prolonged expiratory phase, but don't confuse it with any apneas. This is caused by changes in the pons in the brain, also known as your respiratory center for the body. Number 8 is agonal breathing. It's basically just what the graph shows. You have pauses on both sides and a breath in between, not necessarily in the same place every time. Number 9, shallow breathing, is just fast, shallow breathing in the chest, not filling the lungs with a full tidal volume. Number 10, hyperapnea, is just a faster, deeper breathing. Number 11 is air trapping. You can see these in ventilated patients that are able to get the air in and unable to expire out in COPD, sometimes in asthma patients, and patients that have been mechanically ventilated for long periods of time and are starting to be weaned. This is an example of patients that need to stop weaning. Number 12, Kussmaul's breathing, is an example of labored hyperventilation. It's deep, rapid, and is also seen in acute diabetic ketoacidosis. And patients appear to be air hungry, they will gasp, and it appears to be involuntary. And then number 13, sighing, is just a normal sigh that we all do when we're sleeping. You're breathing normally, and then you take a big deep breath in and let it out, and may do it again. So the pauses in these breaths could result in gasping, grunting, nasal flaring, retractions, and of course loud snoring and snorting. The abnormalities are in the rate, rhythm, and the effort of breathing. Increased work of breathing are using those accessory muscles and may cause the patient to fatigue and decrease effort for that stable breathing, and could cause respiratory distress. Does anyone have any questions? And thank you so much for your support, and hope you all enjoyed the webinar presented today. And here are a couple of the references that were used to make this presentation. Thank you.